Good evening, everyone. I'm Hebzi, representing Science Integra, and I extend a warm welcome to all of you to the 25th webinar of Maha Smiles, Cleft Care for Every Child. This event is organized by MWOX in collaboration with Smile Train India and the Public Awareness Committee of FOXY, with the aim of raising awareness about cleft lip and palate condition in children. It's my pleasure to introduce Dr. Chavi, the Program Officer of Smile Train India, who will be addressing us now. Over to you, Dr. Chavi.
Thank you so much, Hebzi. Good evening, everyone. It gives me great pleasure to share how Smile Train and Foxy have come together in a meaningful collaboration to strengthen cleft care in India. Can we have the presentation? Do you have the presentation, Hebzi? So together we have developed a national protocol for diagnosis and management of cleft lip and palate, bringing together the expertise of fetal medicine specialists, neonatologist, speech therapist, maxillofacial and plastic surgeons, and other professionals to ensure that every child born with a cleft receives timely, holistic, and high quality care. Uh, about Smile Train, so we truly believe that every person deserves access to comprehensive, safe, and quality cleft care, no matter where they live. Next slide. So we have today we have around 57 partner hospitals in India which offer comprehensive cleft care services, and we are operating in more than 130 plus partner hospitals where we provide surgeries to the cleft affected children. Next. So we have established a dedicated cleft helpline, which has received over 9,500 calls since January 2019, connecting more than 6,500 patients with free life-changing treatment across the country. Um, so our flagship collaboration with Bajaj Finserv um, is aimed at enabling more than 8,000 surgeries over the next 36, over the whole 36 months of this project, transforming lives and smiles across Maharashtra. And I sincerely hope that with Foxy, with Amox, our medical partners and initiatives like Maha Smiles, we would be able to build a future where no child suffers because of cleft and every child finds its place in the world. Thank you. Um, I'll hand it over to now Dr. Monica.
Thank you, Charlie, for updating us what Smile Train does. Um, Pepsi, it's okay. Don't put my introduction slide. I am really happy to inform all the people who have joined today, as this is the 25th episode, and Amounts has been constantly in association with the Smile Train, been doing this since the last 3.5 years. The first tenure was with Dr. Pardeshi sir, and Dr. Kiran sir also has extended the association, and I hope that Amay sir also will take forward. And I am with Smile Train with these webinars in the last 1 year. So we have been doing this in every month, and we take topics which are related to the Smile Train, that is the etiopathogenesis, the ultrasound diagnosis, and counseling of the patients, that MTP is not required, and followed by breastfeeding difficulties in these babies post delivery and the post delivery care. The operative procedure, the dental procedures which are required will be taken care by the Smile Train with their speakers. So it is a very good association, and it is necessary that we sensitize each and every obstetrician that an MTP is not required, even if we diagnose a complete cleft lip and cleft palate, and they are completely curable. Thank you to Smile Train for doing such a wonderful job. You're giving them the surgeries absolutely free of cost and the counseling that is required. So I would now request MC for the inauguration slide. We take blessings from Lord Almighty, and then we can take blessings from Dr. Suvarna Madam. So with the blessings of Ganpati Bappa, I request Suvarna Madam to please say a few words so that I can invite our chairperson for the first talk then. We will take Meg Madam's blessings as and when Madam joins. Ma'am, are you there?
She has already given the blessings, I think.
Sure. Nitin sir, can you take the talk first? Dr. Patel sir is busy with the cesarean section. He will join in the 10 minutes. So I request our chairpersons for the first session. Can we have the CV slides, please, Epsi? The next slide, please. Our first chairperson for today's session, Dr. Rajendra Chavan sir, is the president of the Palghar OBGYN Society from 2006 to 2007. He has been the past secretary of the IMA Boisar branch and the president of the Rural Medical Association from Thane district. He is also a member of the Association of Medical Consultants, Mumbai. He is an honorary
Okay, madam.
laparoscopy surgeon. Yes, sir. We
Thank you.
welcome you, sir, to this webinar as a chairperson.
Thank you, madam.
The next slide, please. Dr. Pratibha Madam will join us in the 5 minutes. She's a consulting OBGY in the rural area of Gadinglaj. She is currently the president of the Gadinglaj OBGY Society, and she practices at Sant Gajanan Maharaj Rural Multi-Speciality Hospital. She has a special interest in doing laparoscopic sling surgeries for prolapse and for the gills. We welcome both of you, sir, and I request Rajendra sir to please introduce our speaker, Dr. Nitin Bhola sir. As Patel sir will be joining a little late, and sir can then start with his lecture.
So today we have a speaker, Dr. Nitin Bhola. He is oral and maxillofacial surgeon and practicing for over 20 years in this field. And he is from Wardha. He is director of Siddharth Gupta Memorial Cancer Hospital in Wardha. He is chief surgeon, and I am audible, no? Yeah. He is chief surgeon and
Yes, sir.
director Smile Train Project Wardha. Coordinator PhD and fellowship program in Mexico facial surgery. He is MDS in oral and maxillofacial surgery. Datta Meg Institute of Medical Science, PhD in oral oncology. Datta Meg Institute of Medical Science, fellowship in head and neck oncology. Datta Meg Institute of Medical Science, fellowship in some Linderwood Medical University, Germany. He has also fellowship of Indian Board of Maxillofacial Surgery, and he has a publication more than 200 international and national publication on his name. He has 31 copyright with Government of India, patent with Government of India, which he has done patent with Government of India, ICMR and other funded project as a principal investigator. He has also authored a textbook on this, and he has given keynote of over 150 as a guest lecture, 50 plus workshops, a panel as a resource person. So I request Dr. Nitin Bola to take over and enlighten us. Thank you, sir.
Good evening, Mr. Rajan. Thank you so much for the kind introduction. And I'm just waiting for my slide to get shared. At the outset, I would like to thank Smile Train and Foxy for giving me this opportunity to speak on a very relevant topic amongst people who are the caretakers of this particular area. Hello, am I audible? Hello.
Yes, sir, you are audible.
Yes, so, a very relevant topic on
Yes, sir, you are audible.
cleft lip and palate. Smile Train has been kind to help all these patients of cleft lip and palate for last 17 years. We have been associated with Smile Train, and then we have operated more than 4,000 patients at our institute. Thank you. We cannot thank enough Smile Train because the situation before was used to be very bad. Like the eldest patient I have operated was 65-year-old lady with bilateral cleft lip and palate. So that was the state of affair when Smile Train uh, came in for to help all these patients, poor patients, needy patients, and then the scenarios overall change. Coming to the topic per se, when a child with cleft is born, the birth is there, but it comes with a lot of issues. It comes as a shock to the family like we can correlate. All of us are parents, most of us are parents, and then to have a child with such a deformity can be devastating for the families. And then there are numerous incidences to quote on my behalf also where people have abandoned their kids for want of this deformity. Still in the rural places, it is thought to be the work of evil. And then I see many times kids coming with a lot of, they've been charred with the help of a metal on their abdomen. And that's a very, very, very common thing in this part of the world. But slowly, ever since the Smile Train has come in, the information or knowledge or publicity of the same has helped, and then it is more and more compliance on the part of uh, families we see. But nonetheless, to mention stigma, we cannot say, we cannot avoid that. This is stigma with the cleft, even with the educated parents as well. There's a stigma with the cleft. Uh, there is a lot of pressure on mother who gives child to such a baby because in Indian traditional scenario, it is thought to be her mistake, which is not the scene, but that happens. So mothers, they tend to be under immense pressures, especially what we have seen from the grandparent grandmother's side. So mother faces a lot of psychological issues. So is father. So the parents are into immense pressure when the child is born. When the child grows, the child undergoes pressure in the sense that when he goes to school, it is difficult for him to cope up. Not at the early age, because till the time the child goes into teens, he really doesn't understand what the problem he's facing with. But once he enters into teens, goes to the school, we see that kids have tough time, and then they used to be better compliant maybe a few years back, but with the current era of all the social media platforms where everybody has an uh, compulsion to look good, uh, they face a lot of problems in the school, like bullying from their own peer group because of their looks. There's some amount of scarring there, and then speech, because they will have speech issues, auditory issues. So all these things combined together creates problem for this kind of kids. So it comes with a lot of psychological pressure, impact on the family, and then when it comes in, when the child grows, he has to go through all this. The family has to go through some multiple operations, which starts from say 3 months to 6 months of age, and it lasts about till 18 years of age when we finally do a orthognathic surgery or a rhinoplasty for these kids. Saying so, these are all the problems, but we have a solution for it. And I think this is the best forum where, all the caretakers or stakeholders are in one place, because I think the point of contact with such kids, the first point of contact comes is gynecologist, because once the mother gets pregnant and then goes to a gynecologist during her routine sonological visits, they would identify a patient with cleft. So the first point of contact is the gynecologist. So there has been stress on this, that the gynecologist be made aware of all. They always are, but it is our duty to ensure that if they promise something to the parents, like you can deliver this child because this child can get normal. So we should make it's our responsibility, and as part of surgeon, that we need to make them this child looks absolutely near normal. So it has to be a good amount of understanding between a gynecologist, the radiologist, sonologist, pediatrician, and the cleft team. This, when I say this, that means that we need to give assurance to the family, because this stressed family needs some assurance, because with the antenatal diagnosis coming in, and then more and more technological advancement in terms of prenatal diagnosis, one might be able to get the information that the child is having cleft. So in a way, it is good. I'm going to touch onto it briefly because I think there's a lecture onto it as well. But what I mean to emphasize is we as healthcare providers, especially the cleft management team, the gynecologist, radiologist, pediatricians, we need to be on one page where we can tell them with assurance that no, this child, if at all born with a cleft, can be rehabilitated or cured in a way that he can go back to society like any other normal individual. So as I said, the first point of contact is gynecologist. And the treating gynecologist would, because during the anomaly scan, they will be able to understand. So it is good in a way that we can do a counseling. The child birth is not a trauma to the patient, to the parents. The parents already have an idea that they are having going to have a cleft child, and then we can explain them amicably in terms of treatment which can be offered and how the child can look normal. So that's a comprehensive team we have to build up. And then finally, this patient has to be sent to a comprehensive cleft team. I just put this picture to show this was a girl who came to us with a facial cleft, and then we did multiple procedures on her over a period of around 13 years. And then under many, she went to many places. I happened to treat her twice, and then this is what finally I did for her, and she looks normal. She can go with a smile in society, not with kind of an stigma. So when she sends me, this is a picture she sent me through her phone. So very happy to see. Maybe she would have used some softening app or something, but look at the confidence she has in her eyes and what she used to look before. So this is what we need to counsel this patient, that their kid can look normal. So coming to the topic per se, um, the cleft deformity can be divided into cleft lip and palate or combination deformity. In cleft lip, we see unilateral cleft lips, bilateral, sometimes midline clefts. When it comes to palate, it can be complete, partial, or submucosal. This is the cleft palate situation, which usually goes under notice because parents might not be able to understand submucosal cleft. It's more of a missed diagnosis on part of pediatricians also, or early treating clinician. We need to look for those deformity. Invariably, this comes to the fore when the child starts speaking, and then the child develops some nasality. Then there could be combination of lip and palate, which could be unilateral or which could be bilateral. Let me tell you, all these deformities are correctable, but on a personal note, when I have an experience to put on, because I treat equal amount of non-cleft deformities also. Those are very easy to treat, the non-cleft deformities. Cleft deformities are difficult to treat because it involves a lot of hard and soft tissue, which needs to be corrected. And then the balance of the hard and soft tissue gets altered in many places. So hard tissue, soft tissue, and dentition. So this altogether makes cleft deformity a unique deformity and a very challenging deformity to treat. But thanks, over a period of time, we have learned the nuances of it, and then we are able to deliver whatever best we can do to these patients. The most accepted classification, not most accepted, but the Indian classification is these three groups: cleft lip, cleft palate, cleft lip, and palate. So we're talking about antenatal counseling. So when we counsel the patient, which a gynecologist can very well do, is because, if you counsel it, there is the parents tends to have a psychological preparation on it. They get educated because, especially in rural areas where I work, people still don't understand. There's large population uneducated. So they still think that this is some curse or evil, or maybe some problem with the mother, wrongdoings of mother. So this all needs to be corrected, and the parents can be educated if a proper antenatal counseling is done. The child's parents are mentally prepared when the child is born, so that it doesn't come as a shock or a trauma to them, which usually happens when the antenatal counseling or antenatal scans has not been done. Slight increase in the anxiety of the parents, but ultimately we need to think on these terms also, because the cleft child gets terminated many times. Although we need to counsel them that Isolated cleft deformities are very easy to treat, and then you can have very near normal results. However, severe syndromic deformities where a lot of organs are also involved, there we can think of terminating the pregnancy. But you know that logical reason for terminating the pregnancy has to be ascertained. It's not that an isolated cleft lip or a palate baby should be terminated. That's what we have a responsibility as a gynecologist or as a cleft team. We have a combined responsibility of educating these parents. So this is an interesting survey of parents with affected children indicates that prenatal ultrasound diagnosis enable early education, preparation, high degree of satisfaction with multidisciplinary care. Pregnancy termination for isolated clefting appear to be an uncommon event in the United States and elsewhere throughout the world. So now we see a lot of patients who are born with cleft, who know that they will be having a cleft child, and immediately they are born. So the gynecologists refer them to us for doing some feeding or prenatal, early orthopedic appliances setup. Those can be sent to us. But contradictory, only one-third of the families felt that they had been given adequate information about cleft from their obstetrician or ultrasonographer. All who had prenatal contact with the cleft felt it was valuable. So we need to take out some time to educate these parents about this deformity and the possible outcomes that can be achieved with surgeries. So immediate postnatal, once a child is born, so what we should be doing, immediate postnatal management, the issues could be on airway. This is more so in syndromic cases where you have some associated microsomias or micrognathia where the jaw are underdeveloped, so the contact between tongue and the posterior wall of pharynx is too small and the child is not able to maintain. So this has to be identified because this can lead to mortality. At many places, cleft children's that used to be data, not now. 1 out of 10 child dies within first year of their life. Second is establishing feeding. So we need to, this is the most important thing because the child with cleft lip or palate would have difficulty in creating that suckling effect because of loss of air, loss of contact. So that has to be examined, and then proper knowledge about it has to be shared with the parents. As I said, critical airway obstruction happens because of micrognathia, say Peary-Robin sequence. In such cases, you'll have a jaw which is deficient and the child is not able to maintain. So depending upon the gravity of situation of airway embarrassment, different treatment protocols are given, right from tongue stitch to tongue lip adhesions to early distraction osteogenesis, whereby the lower jaw can be lengthened and the airway can be improved. As I said, in non-invasive, it could be prone positioning, column is cleared so that the air can enter. Or if that doesn't work, then distraction osteogenesis, which we do usually at the age of 1 year when the child has some amount of bone. Although early distraction osteogenesis have been mentioned in literature, but what at our center is we try and do those distraction at the age of 1 year. Tracheostomy, although an option, but again, it should be for temporary setting, not a permanent setting. One should be establishing feeding. An estimated 1 in 10 children born with cleft lip or cleft palate will die before their first birthday. So most of the time this happens because the child is malnutrited, not able to, because this patients, when they try and gulp the milk, the air goes with, they will have a lot of aerophagia. So the child is not able to consume the milk properly, and hence that leads to malnutrition. So we need to counsel the patients and parents, or counsel the mother especially, for feeding. The infants may have difficulty creating adequate suction for normal breastfeeding. So what we have seen is the mother tends to put the child in such a way or in such a particular position where the child can suck. So that's an adaptation which mother and the child undergoes over a period of time. But we should necessarily ensure that the mother tries and feed the child properly in a proper position so that it doesn't choke him, or there should not be any regurgitation of milk into the nose. Children with cleft lip and palate may be slow to feed because, as I said, the suckling doesn't work. They tire quickly when feeding. They swallow excessive air, so that leads to a pseudo sense of belief of satiety, and that for that the child has to be burped intermittently, and then there's a particular position in which the child should be kept, whereby the excessive air can be removed. You should promote breastfeeding, feeding with breast milk when possible, to identify a feeding position which maximizes suction and to reduce regurgitations. So these are some feeding position, and then uh, you know the mother who has an experience about feeding can be the best person to guide a mother who is having a cleft child now. So what we do at our place is we have nurses which would guide them on how they should be feeding, and then preferably breast milk is the best thing to happen. But if you're using bottles, then the bottles has to be nicely cleaned so that the child doesn't catch up with infections. Encourage mother to put the baby to breast for 5 minutes on each side, even if suckling is inadequate. This will promote bonding as well as improve the milk supply. As I said, you should maintain the hygiene of the bottle so that the patient doesn't get infected. And there are specialized bottles available in the market, which can be used to feed the cleft babies. So this was about immediate post birth, the care has to be taken, and when this child gets birth, what we now ask all our gynecologists is send them early because of this phenomenon, because the child in the early period of time, like say before 16 weeks, would have higher levels of maternal estrogen. So what this does is the elasticity of the tissue is there because of this maternal estrogen. The blood level of hyaluronic acid, which causes intercellular matrix to even disconnected. Because of these high levels, you can mold the alveolus, you can mold the nose, and with this, the concept of nasoalveolar molding or pre-surgical infant orthopedics has come in. So in short, we call this NAM, nasoalveolar molding. So what are the objectives of this PSI? Why I'm telling this to you is because many times we see that child doesn't report to the hospital till 6 months of age or so. Then the precious time, that first 16 weeks, are lost. So if the child comes within that period, we can create an orthopedic appliance whereby the severity of the cleft can be reduced. If you see the patients which are not been treated with NAM, they will have severe cleft deformities. Now that can be reduced taking help of this natural phenomenon whereby the elasticity of the bone can be brought, and then the cleft alveolus can be reduced, or the nasal cartilage can be modified. And hence, it is important that these children should be immediately sent to the cleft team for a possibility of an infant orthopedics. Although there's a controversy on whether we should be doing an infantile orthopedics or not, there are proponents and opponents of it. We in our place, we follow NAM, we use NAM, and we have seen that it significantly improves the outcomes of a primary repair. So this is what I was trying to tell you. These are two segments of cleft palate, and then by putting this retention taps or NAM appliance, we can get this closer. This can be modified, and then a wide cleft looking cleft can be converted into a narrower cleft, and a slumped ella of nose can be slightly modified in terms of shape. So the nasal outcomes also improves when we use NAM as a modality. This is just an example of a small kid been referred to us, and you can see that this is her cast when she's born, and then this is after her NAM appliance has been set in, and then after repair, you can see a nice arch form is there. This is because we could modify now with this picture, you can very well appreciate. Look at the amount of cleft gap we had. Look at those here. So with the NAM appliance, we can get this closer. So once we get this closer, people who've been treating cleft would understand that repairing such thing becomes slightly difficult in terms of achieving a good closure, a tension-free closure, a good shape of the nose. So with the advent of NAM or orthopedic appliances, this can be closed, and then better results can be obtained. Just few examples of it. You can appreciate the amount of fullness we can get when we get this alveolar arches close. So this was after birth, and then immediate after birth, we can send it for NAM, and then speech and language treatment protocols, because this is the one very important aspect of it. When the child, usually we do a lip repair at the age of 3 to 6 months, and then palate repair from 9 months onwards. This child, when starts babbling, that's the time when you should be doing the palate repair. And then this patient always requires speech and language assistance because of the issue of hypernasality. So at the 6 to 10 months, communication screening should be done, counseling of parents about language development and language stimulation. From 18 to 30 months, we do language assessment and management through parent training. Then then institute-based language intervention if indicated, speech sound assessment. Then we do an articulation correction, resonance assessment, and management if indicated. So depending on the severity of the hypernasality, in our center, most of the patients all would go for speech and language treatment protocol. So this is timelines for cleft care. So after birth, assessed for associated anomalies, especially when you have lip and palate, you should go for additional screening to look for any other syndromic deformities being present there. You should assess the child carefully for all the anomalies. At 3 to 6 months, we do a lip surgery, and from 9 to 18 months, we do palate surgeries. From 6 to 12 months, ENT assessment to rule out middle ear, because this patient would have a lot of middle ear infections. So we need to rope in an ENT surgeon. Or for 5 years or so, we go for speech therapy. After 5 years, we go for vilopharyngeal dysfunction assessment and surgery if required in form of pharyngoplasty. And when the child is 7 to 11 years of age, that is the time when the permanent teeth come in, anterior permanent teeth come in, and typically when the canine starts erupting from when the half of the development of the canine, half to 3/4 of the root of the canine is formed, that is the time when we try and put an alveolar bone graft there so that we facilitate the eruption of this tooth into that alveolar cleft cap. Once this is done, when the child turns teen and then the age, the puberty has been achieved, that is the time when we go for orthognathic surgery that typically happens at the age of 16 years plus, and then finally rhinoplasty. So there could be change of protocol. Many people do lip nose correction before rhinoplasty, before orthognathic surgery. At our center, rhinoplasty is the last thing, the last procedure, the definitive rhinoplasty I'm talking about. Although there is a concept of prescrew rhinoplasty as well, but the final rhinoplasty has to be done after the orthognathic surgeries in form of maxillary advancement has been done. So this is what schematic diagram showing how. So basic thing is that we need to understand that this child from the age of 3 months till 18 years would have to undergo various surgeries. So we need to guide them that it's not only the primary lip repair or the palate repair that is going to suffice, because these children would have dentition problem, eruption problem of tooth, arch collapses, because of the primary repair in the lip and the primary repair in the palate. There tend to be a hypoplasia setting in the maxilla. This is maybe, because of the fibrosis which we induce in the primary cleft palate surgery, whereby the raw areas in the nasomaxillary area, especially in the pterygomaxillary area, this leads to a lot of fibrosis, and there is a contraction of tissue in this area that leads to some amount of hypoplasia, which could be vertical or a horizontal hypoplasia. Although that can be minimized by lining the raw areas with the fat or primary closure and the lateral aspects as well. That's what we are studying now. So if I have to sum up, then lip repair at the age of 3 to 6 months, palate from 9 months onward, followed by a VPD assessment and treatment if required, vilopharyngeal dysfunction. That's in general language called as hypernasality. Followed by that, we need to do a bone grafting between 6 to 10 years of age, typically in orthognathic surgery at the age of 16, and a rhinoplasty before or after that. So this is early birth to 24 months. From birth, we need to send this child to the cleft team, and the cleft team performs all these procedures which I have mentioned. Mind well, it was, few years back, maybe, where treating the primary lip or closing used to be the norm. or a palate closure. Now what we trying to work on is the ultimate final finish or niche of it, whereby we tend to look into speeches, we tend to look in terms of nutrition, we look go and look in terms of aesthetic outcomes finally. So the cleft treatment has also evolved from, we used to have safari surgeons coming from out somewhere and then operating our kids, and then now we see those kids, they are into terrible shapes, their arches are collapsed, they have bad palate. So my urge is that we should definitely not allow this to happen and then send them to a more dedicated cleft care center. So as I was saying, see, look at these parents, they get these kids, and then eventually when we operate them, they tend to grow up confidently with the help of their parents, with the help of the cleft team. You can see the smile on their face. This example of unilateral lip, and then after the repair, this nose is, the nose again is in, one area where we need to really work on. We've been working constantly to get good results out of nose. But again, that's one enigma, even for every cleft surgeon. Another example where you can see a unilateral lip which has been repaired, and the outcomes are good. The patient become confident. Somebody's speaking, I don't know. Other case where you can see, these are a few examples of unilateral lips, which I was just wanting to mention. The idea is that we can create marvels. We can create almost near normal looking faces, near normal looking noses, and then the final outcomes of it could be individual which can go back into society with confidence as equal to any other normal human being. As I was saying, NAM does pre-surgical orthopedic, but that doesn't mean that without NAM you cannot do. And in this case, you can see this recently treated. You can see this jetting premaxilla out and the pro-label segment almost into the nose. A good repair of muscle at the level of alveolus can really cause and put an orthopedic force onto it only by the help of muscle repair, and you can have a good outcome. And this is a baby after 3-4 months now. So the entire premaxilla has gone in. The lip shape looks better. That was lip, and then similarly palate. As I said, I tend to put the fat around it so that I reduce all those areas where later on the chance of hypoplasia can be reduced, or if possible, then I would like to put it back into the place where I took it from. So lateral tugging, so that reduces the amount of fibrosis that sets into this area. So I was mentioning these are normal deformities. We are used to treating them, creating faces which can go back into society and then walk out with confidence. But cleft deformities are different from this deformity. These are all aesthetic deformities, non-cleft deformities. But being a maxillofacial surgeon, I have a opportunity to treat all of them. And the same knowledge can be applied onto cleft patients also, whereby we can do distractions or orthognathic surgery once the child has achieved the teenage, and then after 16, typically what we do after growth is completed, we tend to, because as I said, this you can see this hypoplasia of maxilla. She's a teacher. So now she wants to teach and she has a reasonable speech. So when we do a Lafort 1 level advancement or Lafort 1 level distraction, although we tend to get the maxilla forward, but there would be some changes in the speech. The vilopharyngeal dysfunction can aggravate, and hence we do an anterior maxillary distractions in this case. This is just an example I'm trying to show. So only with the anterior maxillary distraction we can get a good advancement of lip without hampering the speech. So with distractions, with orthognathic, we can go and finish these cases as near as normal as possible. Just to conclude, this is a girl who came to me and she's very depressed and then with suicidal tendency because of her looks. So lip repaired somewhere long time back by some safari surgeon, and then the palate has a huge large alveolar cleft. She was denied by a few centers, then she came to me. So that's what did is we did a maxillary advancement in form of distraction and a mandibular setback by doing a one-stage orthognathic surgery with a rhinoplasty. This is her then this is how she looks more confident. So that's what we can do to them. And then nothing more satisfying than seeing a patient with cleft going out in society with such a confidence. Thank you so much, ladies and gentlemen, for patient listening.
Thank you, sir.
It was nice.
Yes, sir. Sir, over to you, Rajendra sir and Pratibha ma'am, for your remarks, sir.
Yeah, it was an amazing results we could see, and really very encouraging for all our gynecologists that many people they come in a village to us, and then they tell, "कि भाई, ऐसा निकला है, this is diagnosed and left lip is there, and or so we don't want to continue." We always try to encourage them, and these are some of the picture I have screenshot, and these are nice to show them, and it is really a good result, and you are doing a great job, Dr. Nitin. So we really compliment you. And it was a nice presentation. Thank you, sir.
Thank you so much, sir. Thank you so much.
Pratibha ma'am.
Yeah.
Very nice presentation by Nitin sir and very nice photographs like a heroine only. And I appreciate you. But there should not be surprise for the mother as well as family. And that's why prenatal diagnosis is very important thing and that you highlighted. As in rural area also now people are accepting in good way and machines are nowadays very good. That's why pickup is also very nice. If isolated anomaly and if we are counseled prenatally only, then they are accepting very nicely. And there is a role of again after the delivery obstetrician as well as pediatrician as well as our nurses. They should as you said, there is 1 out of 10 died. That's why there is a need to proper weight gain and proper feeding management, KMC care. That all things are again teamwork. And if that is happening, then only results are very good. And because of this Smile group, all the surgeries are free. And that's why again they are accepting very nicely because of free. And that is one good thing. And this facility is available free of cost and very nicely you explained all the points. Thank you very much.
Thank you.
Thank you, Nitin sir, for an elaborate talk. And thank you, Pratibha ma'am and Rajendra sir, for chairing this session. We now move forward to the next academic talk, which will be the medical legal aspects of missing an anomaly, which will be taken by Dr. MC Patel sir. And I would like to introduce Dr. Anil Sakre sir as a chairperson for this session. Can
Thank
we
you,
have the
madam.
slides, FC?
Thank you.
Thank you, sir. Thank you so much. FC, can we have sir's CV? Dr. Anil Sakre sir is a renowned vaginal surgeon in Maharashtra. Sir has been the associate professor in the Department of OBGYN at the SC Government College, Nanded. Sir has also been the past president of the Nanded OBGYN Society, and he has received more than various awards for his cases through the African countries through Rotary. He has also been the organizing secretary of AMOX 2012 and 17 at Nanded. We welcome you, sir, as a chairperson. Dr. Ujjwala madam is busy in a surgery. I will still, she will join in sometime. She is a postgraduate from Solapur and she's the director of Yash Nursing Home and Sonography Center. She has been the president of the Indian Medical Association Bhiwandi for the last 5 years, and currently she's the vice president of the Thane OBGYN Society for Obstetrics. We welcome both of you to chair the session, and I request Sakre sir to please introduce Patel sir.
First of all, sorry, I joined a little late.
Yes, ma'am.
Just completing Caesar. So thank you so much for making
Thank
me
you,
the
ma'am.
part
Thank
of
you for
this,
joining
meeting.
in time, ma'am. Thank you.
Thank you, Monica. Giving me it's a pleasure to introduce a legendary in our Foxy, Dr. MC Patel sir. I think he don't need any introduction. He's such a person, lovely, lovable person in Foxy, and he has done a lot of things to the all gynecologists who are working, particularly in small places. I really appreciate his work, helping in all medical legal cases, giving them the advice and helping them till the end. It's really an appreciable thing for MC Patel. What I know him, he has an consultant obstetrician gynecologist, medical legal counselor, candidate for, but he's my favorite candidate for Foxy President election 2025-2026 and hope, sir, we will see you as a President Foxy in 2026. President AOGS 2010-11, President IMA Ahmedabad, National President NMO, Organizing Chairperson Vivekanand NMO, Vice President Foxy in 2018, Chairperson Ethics and Medical Legal Committee 2011 and 13, Honorary Secretary State Organization of Gynecology and Obstetrician of Gujarat in 2022 to 2025. He has services in medical camps in Northeast states and Dhanvantari Seva Yatra under NMO and Seva Bharati organized since last 23 years, and he regularly visits the states like Nagaland and Arunachal Pradesh and offer his service at a free of cost. I really appreciate his service, and I many times I have asked that I am ready to come with you. Probably in next 1 or 2 years I will be with him in these states. Sir, this dais is yours. We welcome you on this dais.
Thank you, Anil, for kind words. And let me share my screen. Is it seen?
Sir, we still started sharing. Now it is seen, sir. So can we make it full screen, please?
1 minute. Yes. So thank you, Anil, for kind words. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Legalities in fetal anomalies, when we miss this anomaly during antenatal period, and we have to face litigation in this type of situation. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Monica in particular for inviting me to share my views about the subject. Usually I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. Any area you can take, either CPA, civil suit, criminal cases, Human Rights Commission, Medical Council, gynecologists are in driving seat as far as any litigation part is concerned. Let us see few of the cases. These are real happened cases decided by different courts. So in this particular case, a patient was referred to sonologist for almost 4 times, and every time report was no obvious congenital anomalies in fetal head, abdomen, and spine. And ultimately, at due time, cesarean section was done, and baby was found to be agenesis of fingers, right leg below knee, and left foot below ankle joint. So it was agenesis of all this, and case was filed, notice was served. So allegation on part of patient and patient's relative to the radiologist was radiologist neglect performed USG and issued wrong report. It was negligent performance on part of radiologist was the allegation. It was possible to detect anomaly between 12 to 14 weeks of pregnancy, but opponent party, that is radiologist, failed to detect all the anomalies during 2nd, 3rd, and 4th USG, and most importantly at 17 to 18 weeks of scan. Baby was thoroughly examined by child specialist after delivery, and it was found to be with left eye closure problem, poor blink reflexes, watering, and micrognathia with microglossia. So there was left-sided facial palsy, poor jaw opening. So there were multiple anomalies in this particular child. And after delivery, scan of baby for KUB and abdomen was done by S. Suresh, and it was found to be normal. But allegation was that baby would have to go for different surgery at least 7 times, and it will be very troublesome economically and otherwise also for the family. So compensation of 10 crores, 8 lakhs and some thousands were demanded, and defense on part of radiologist was denied any negligence to perform and report sonography of patient. He raised preliminary objection on maintainability of the case because it was exaggerated claim demanded, so case should not be maintained. He admitted that he performed routine level 1 scan and all the time, and it was not targeted scan. And he also admitted that I charge accordingly rupees 300 or 400 for basic sonography on each occasion. Anomaly scan USD, which is known as a target scan, would be charged of rupees 1,200, but it was never advised either from patient or relative or from gynecologist. So at no point of time, just I mentioned, either gynecologist or patient or relative had advised to go for target scan, and patient was not charged for target scan. These were some poor defense, I would say, on part of doctor in court of law, and ultimately a complaint was maintained in this particular case, and defense on part of doctor was this also: commonly all over world, as a standard protocol during level 1 scan, radiologist will check for fetal presentation, amniotic fluid volume, fetal cardiac activity, placental position, fetal biometry, maternal cervix, maternal adnexa, and reporting format of level 1 and level 2 scan are totally different, was argument on part of that radiologist, and charges are also different in both the scan level 1 or targeted scan. And treating obstetrician was also aware limitations of standard and targeted sonography. So anomalies are missed due to level 2 scan during level 2 scan also, even with base 10 and center. But as far as judgment of this particular case is concerned, medical negligence was attributed to the doctor, and patient and patient party were awarded rupees 1.5 crore in this particular case, and out of those 1 crore was to be deposited in fixed deposit, and till baby attains majority it will be in fixed deposit, and care will be taken by parents, and rupees 25 lakhs were paid to parents for further treatment and mental agony they face due to this anomaly to their baby. So in this type of situation, they also awarded 1 lakh rupees total legal expenses also. So let us see one more case. Regular antenatal care, USG scan at every pregnancy, 11 to 13 weeks, 22 weeks, and 32 weeks. Normal report every time, delivered by cesarean section, and baby was found to be a case of cleft palate and cleft lip. Let us see one more case. Antenatal care by another gynecologist. This is the real happened case, and this patient had to me only. Came at 34 weeks of pregnancy for very first consultation. Routine investigations were advised, including sonography, and sonography report, which I advised, was also reported to be normal. And baby was delivered vaginally normally, and it was found to be a case of bilateral absence of fibula. One more case. Regular antenatal checkup, sonography every time up to 24 weeks of pregnancy, gave normal report every time, no sonography after 24 weeks of pregnancy, delivered normally vaginally, but baby handed over to neonatologist present in labor room, and after 1 month, baby was diagnosed to be a case of achondroplasia, and case was filed. I was defending this gynecologist in court. Ultimately, we won this case, but these are the cases we have to face in court of law. Regular antenatal checkup at Rajkot, which is town place of Gujarat, came for checkup very first time to me and subjected routine investigation with sonography, and it was found to be a absent right-sided nasal bone. So patient is yet to deliver, but patient was insisting me to go for termination of pregnancy merely on ground of this absent nasal bone. So I explained are very thoroughly and relative. I sent them to plastic surgeon also, which are the alternative after delivery, and they are continuing with delivery. So in this type of situation, we have to counsel patient accordingly also. This is also one more real happen case in state of MP. So patient was advised to go for sonography at 20 weeks 6 days gestational age, and these findings were that there was no anomaly and fetal spine, trunk and limbs are normal. Again, after 3 months at 30 weeks, 32 weeks, the same patient was referred for sonography to another sonologist, and findings were 32 weeks 1 day, severe oligohydramnios, and fetal spine, trunk and limbs are normal. So both the sonologists mentioned that fetal spine, trunk and limbs are normal. So in this particular case, delivery was done and baby of 1.500 gram was delivered with this absent left upper limb, absent left kidney, lungs not fully matured, fused spinal cord, and after this surgeons, pediatric surgeons, plastic surgeons all were consulted, and they advised certain correction of neck and spine deformity, but chances of paralysis were also explained during this surgery or after surgery, and there was single kidney, so chances of renal failure was also explained. So defense on first sonologist was 30 years experience in radiology with sonography, and doctor advised only to confirm duration of pregnancy. So he did only basic and routine sonography and following standard procedure with due diligence. And second sonologist defense was the same. Organ imaging depends upon the position of fetus, and absence of organ could be visualized with most difficulty. Routine prenatal sonography is very basic scan and lasts only for 10 minutes, during which position of fetus cannot be changed to view it from other side. Every gynecologist and radiologist are fully aware of inherent limitations of such sonography. So it was very poor defense, I would say. It lasts only for 10 minutes is no defense, because there is no time limit given to you that you will have to examine that very patient in 10 minutes only, and you have to come up with all the anomaly fetal baby is having. So this was very poor argument on part of radiologists. They had also one more argument that fetus was lying on its side with upper limb tuck up underneath, so it was impossible to see any limb was missing, nor was there any region to assume or suspect congenital anomaly suffered by fetus, rather very rare and extremely difficult to detect even with repeated examination with best expertise and with modern equipments also. So routine scan cannot detect such anomaly. It needs advanced targeted or anomaly scan. It should be advised by treating doctor, because they refer Culling's textbook, and in that it is written that radiologist or sonologist would not do by his own, and whatever is advised to them, they will go for sonography accordingly. But again, this was not taken into consideration in court. So one more argument on part of sonologist was purpose of obstetric scan is to see fetal growth and gestational age of baby, and in small proportion gross malformation may also be detected. Type of examination depend upon the request from gynecologist. So these were the argument from both the sonologists, but inference held by the National Commission was, if radiologists could not see limb due to tuck-up position, then how both of them opine fetal spine, trunk and limbs to be normal? Casual approach on part of radiologists was considered by National Commission, and it was considered dereliction on duty of care. So compensation of rupees 15 lakhs was awarded in favor of patient and patient party. So with all these cases, where thing goes wrong? Delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, missing anomaly or anomalies, wrong diagnosis, unnecessary investigation. Many times we are not sure of our findings, so we may advise them to go for repeat scan. So they allege that it was unnecessary investigation, no proper consent or proper counseling, communication failure, because failure to communicate a result of ultrasonography investigation in a timely manner. Because many a time if we explain everything in a best manner, then chances of litigation may be minimized. As far as complication related to that anomalies are concerned, fetal morbidity or in few of the cases, fetal mortality. As far as PCPNDT issues are concerned, centers should be registered, person must be qualified, and filling up of the form should be there, and declaration on part of patient and doctor should also be there. Because all these cases, when something goes wrong, they will also allege that no sonography form was filled. So we have to see that part also. And very important part, when this type of anomalies are detected, and particularly when anomalies are very minor, cleft palate, cleft lip, or polydactyly or so, in this type of situation also, few of the patients are interested to terminate pregnancy. So as far as this MTP issues are concerned, center should be registered, person must be qualified, and filling ups of the form A, B, C, D, E, 1, 2, 3, as per the case may be. But if we go with provision of MTP Act up to 20 weeks of pregnancy, child were born physical or mental abnormality has to be seriously handicapped. Here word seriously handicapped is used. So you can terminate pregnancy up to 20 weeks of pregnancy in fetal congenital anomaly when it is seriously going to be handicapped. If pregnancy is more than 20 weeks and less than 24 weeks, because many times such anomaly may be detected little late. So there is provision, but again in this provision also, fetal malformation that has substantial risk of being incompatible with life of fetus, then only you can terminate pregnancy up to 24 weeks of pregnancy. If pregnancy has advanced 24 weeks and certain anomalies are detected late, so in this situation also, you can have opinion from medical board, but medical board has conferred power to opine in case of substantial fetal congenital anomaly incompatible with life of fetus. So anomalies, if they are incompatible with life of fetus, then only medical board will opine and you can terminate pregnancy. So these are the issues as far as termination of pregnancy are related. So in this situation, you will have to advise patient or patient party to prefer writ petition before Honorable High Court seeking permission of termination of pregnancy. But again, in this type of situation, court is also very clear. If anomalies are not incompatible with life of fetus, even court will also not allow to go for termination of pregnancy. If pregnancy has advanced and if it is substantial congenital anomaly, Honorable Court will ask medical board, can pregnancy be terminated on not legal ground? Legal ground is clear now. On medical ground or as far as physical capacity of patient is concerned, is she fit to go for termination? And if there is opinion from medical board, then court may pass order in few of the cases to go for termination of pregnancy. So whenever you are facing this type of problem, usually you have to face this question: was it preventable? So was this anomaly which you missed was detectable at that point of time when patient had been to you? And usually you cannot say no. So many times when answer is yes, then what did you do to prevent it? To prevent this missing of anomaly. So, and why you couldn't prevent it? In spite of all our care, caution, you couldn't prevent, you couldn't diagnose or detect, and baby delivered with anomaly. Then this question is also asked in court of law. Was it possible to detect anomaly in time, and where these anomaly were very rare or difficult to diagnose? These are the questions you have to face in court of law. So if radiologist could not see limbs due to tuck-up position, then why one opines everything is normal? Say for example, fetal spine or trunk or limbs. So it is very clear in this type of cases, court is very clear and asks, when you are not sure of your diagnosis, how you could stamp report to be normal. So reason one is litigation or dissatisfaction on part of patient and relative, forgetting to screen for anomalies in a proper way. So we have to strictly go with protocols and checklists. Never report normal. If you could not see any part due to position of fetus, you can advise repeat scan. You can have an opinion from senior colleague, but ensure that you will not miss any important finding, because every fetal anomaly is potential threat. But in this type of situation, when you are facing in court of law, you can refer standard textbook, and detection rate is also taken into consideration in court of law. So if it is very rare anomaly to be detected at that point of time, then court may be pleased to allow us, and they do not consider doctor negligent. So look like avoiding medical legal problems in our practice is a difficult balancing act. No, then what to do and how to prevent? Practice foreseeability, anticipation, good communication and consent, and proper documentation, and you will be simply sail through. So as far as anomalies are concerned, as far as heart defects are concerned, congenital fetal heart occurrence rate is 1 in every 1 in 10 births. Ventricular septal defect, Fallus tetralogy, pulmonary valve atresia and stenosis, neural tract defect, Down syndrome, exophthalmos, hypospadias, club foot, cleft palate, cleft lip with cleft palate. So these are the anomalies usually we are referring patient to see all these anomaly. But proper counseling after report is also very much important as far as proper counseling is concerned. Usually any of our counseling we start with what is the complaint in routine manner. But as far as this sonology part is concerned, then we have to explain patient about dual marker, NT scan, nasal bone, TR and DV, then quadruple marker, NIPT, PGD. So if you explain about all this to have a confirmed diagnosis or to rule out all these anomalies in a better ground, then we have to explain all this. If patient doesn't follow your instruction, if patient doesn't go for any of these tests, then it becomes a contributory negligence on part of patient, and it becomes good defense in your favor. As far as this detection rate is concerned, in so many this anomaly, detection rate is stamped in standard textbook to be 95%. NT and double marker, nasal bone, TR, DV, if we have all this advice, and even then if we have missed any anomaly, many a time reports turn out to be normal, and even then there could be some anomaly. But if report has turned up normal, then your consent is taken in that way that you had tried your level best, but some anomaly missed by person who had done that very scan or any other markers. As far as false positive part is concerned, almost 2.5% are taken into consideration in court of law. But if we can convince court, because court is not expert in medicine, so we have to convince what is false positive and what is false negative. And if we can convince and detection rate and how it can be missed, then many a times court can be kind enough to leave us without any negligence. As far as NIPT is concerned, we know 99%. So in this situation, if we have explained everything to the patient, then it becomes easier for us to face in court of law. But whatever you explain to the patient, it should be in a very simple language. So avoid medical jargon at the time of counseling, and no rosy picture about result, no tall claim about result, because we consider result of our sonography as far as anomaly scan is concerned like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim in this type of situation. So proper communication before scan, after scan, proper documentation, and when you have properly counsel patient, it becomes a documentation of your communication. And when you offer all this report before Honorable Court, it becomes a communication of your documentation. And as far as records are concerned, keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. So there is always a way. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So there are a few defense also in this type of situation in court of law. But we should offer all this defense, and we have to convince court why this anomaly was missed. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So to conclude, be vigilant in your practice, and at the time of scan, remain alert every time. Otherwise, be ready to face this type of situation in our practice. Follow standard protocols and guidelines as far as sonology is concerned. Follow up and references, if at all it is required, then we have to ask patient to come for follow up, or we have to refer patient to senior colleague, and comply with the provisions of law. Take medical legal advice from point 1 if at all you are in doubt. And if you want to sleep like this, take tender care of your patient, comply with provisions of law, pray Almighty God before going to sleep, and keep my visiting card below your pillow. So all the best. With regard, salute to all, and my humble appeal to endorse my candidature for post of President Foxy, election year 2026. Thank you very much. Please do not assume. Please ask any query, any question, if time and chairpersons permit. So thank you very much.
Thank you, sir, for an elaborate talk. And I would request Ujwala madam to please give her
Thank you
concluding
so much,
remarks.
sir. So detailed, interesting, elaborated information and case presentation by your side. Every sentence, every word was knowledge and some additional courage and teaching, taking care of every step during our practice. So I wanted to ask you, sir, has anybody sued any gynecologist ki he has not advised proper sonography?
So again, I mentioned during talk also, we have to practice as per standard medical norms. So in this type of situation, court interprets that that patient would have been to another gynecologist, what he or she would have done. So if majority of the gynecologists would advise routine scan at 11 to 13 weeks of pregnancy, then naturally court and law expect us from us to advise our patient to go for scan at 11 to 13 weeks of pregnancy.
My question to Patel sir, that basically it is a revision type. It will be a revision to all the delegates. What is the basic difference between amendments of law from 20 to 24 weeks? What is the basic difference? And second question is that many times I have observed that if an anomaly is documented on paper and patient comes to you with 22 weeks, at many centers they want that this anomaly is lethal or non-lethal. Is it in the law that only lethal anomalies has to be terminated and non-lethal anomalies not to be?
Yes, I mentioned during my talk also, if any congenital fetal anomaly which are incompatible with life of fetus, you can terminate pregnancy on that ground. There are some other grounds also. Say, for example, failure of contraception up to 20 weeks of pregnancy. Mental or physical harassment, if pregnancy is continued to mother, is also one more indication. But as far as fetal anomalies are concerned, if we are going to go for termination of pregnancy on this ground, then in this situation, anomaly should be incompatible with life of fetus.
Okay. Thank you, sir.
So I would like to take your leave because I am busy with one more webinar. So please.
Sir, I have started it, sir.
Okay, no issue. So I am joining there. Thank you, Monica.
Thank you so much. Thank you, sir.
Thank you, Monica. Thank you.
Thank you, Sakti sir. Thank you, Ujwala ma'am. Thank you, Pratibha
Thank you,
ma'am. And thank you,
Monica.
Rajendra sir.
Thank you so much.
Thank you.
Thank you. I would extend my thanks to the Smile Train and Science Integra for giving us the technical support and the academic funding for this program. And we wish to continue this every month so that every gynecologist becomes aware that no cleft lip, cleft palate baby should be aborted, and we can give them a proper prenatal and postnatal counseling. Thank you so much, FC and Charvi ma'am. Thank you for the opportunity. And I would like to thank Dr. Kiran Kurtukoti and Dr. Bipin Pandit sir, AMOG's office bearers, for giving us an opportunity to conduct this under the AMOG's banner.
Thank you all. Bye bye, Monica.
Thank you.
See you.
Thank you, ma'am.
Thank you,
Thank you,
Monica ma'am.
doctors.
Thank you.
Thank you, Rajendra sir, Pratibha ma'am. Thank you.
Thank you.
Thank you.
Thank you,
Bye bye.
Rajendra
Thank you,
sir.
everybody. It was nice.